That anybody with lungs is at risk for getting lung cancer.
I have been told that I didn't deserve to have a program, a treatment that saved my life, basically, because I smoked.
He's had what we call a complete response. The cancer completely disappeared, and his prognosis is looking really good.
From the Zoomerplex in historic Liberty Village, the Zoomer with Libby Znaimer.
Welcome to the Zoomer. I'm Libby Znaimer. Lung cancer is the most commonly diagnosed cancer in Canada and also the leading cause of death from cancer for both men and women. But there is hope in the fight against the disease with a number of medical advances. On today's show, new therapies that will help more Canadians survive and live better than most of us thought possible just a decade ago. But before we dive in, let's tee up the topic.
On average, 81 Canadians are diagnosed with lung cancer every day, and 58 Canadians die from it. Nearly 30,000 Canadians will be diagnosed with lung cancer this year, approximately 13% of all new cancer cases. Meanwhile, 45% of Canadians with lung cancer say they delayed going to their doctors because of guilt over their bad habits. But there is good news in the fight against this disease. Deaths are declining more than 2% per year, and advances in treatment are making the difference.
So just how common is lung cancer, and at what stage is it usually diagnosed? Let's begin with Dr. Snow.
Lung cancer currently is the most commonly diagnosed cancer when you look at all men and women in Canada. It's second to breast cancer in women and second to prostate cancer in men. However, it does account for the number one cause of death in both sexes. We're hoping to see that change as we see the long-term impact of different lifestyle changes, but because of the latency between cancer risk development and exposure, it takes many, many decades to see that impact.
Dr. Melosky, at what stage do your patients usually arrive at your office?
Unfortunately, the sad truth is that, as we heard in the video introduction, is that most patients are stage 4. And we sort of think of patients with stage 1 and 2 that are taken to surgery with curative intent. We think of our stage 3 patients that we often try to cure them as well with combined chemotherapy and radiation, followed by immunotherapy. But unfortunately, the sad fact is most of our patients that see me have stage 4 disease or distant organ involvement.
Dr. Wheatley-Price, is it the same in your practice?
Yes, it is. And there's lots of data really now from each province that approximately 50% of lung cancer patients are stage 4 or metastatic when diagnosed. Another 20% stage 3, where the cure rate is possible but is low. So it's about 70-75% at those advanced stages. But if we can introduce lung cancer screening, then in people who go through screening, 75% will be diagnosed instead of 3 and 4 at stage 1 and 2. Where the odds are in their favor.
What about the survival rate?
Well, survival rates, actually, the Canadian Cancer Society produces our annual cancer statistics, and the overall 5-year survival rate, which is a sort of benchmark that we use for lung cancer, is 22%. That sounds dismal when we think of prostate cancer, 91%, breast cancer, 88%, colorectal cancer is about 65-66%, lung cancer is at 22%. Actually, that's a high watermark. It's jumped 3% from last year, and it's the highest we've ever seen. Among women, the 5-year survival now is 26%. So there's certainly progress, but you can see from those numbers, super long way to go.
And Dr. Snow, is the increase in the survival rate, is it because of new therapies, or what else would you attribute it to?
I think a lot of it is due to the new therapies. We're very at the early stages of rolling out our screening program, so it will take longer to see those impacting Canadian statistics. We're getting better at doing molecular diagnosis, which means finding specific, unique aberrancies in cancers that we can target with therapies, and also the advent of immunotherapy, which really we've been using in our practice since about 2015, has made a big impact.
Debi Lascelle, you are a survivor. That's really good news. Can you tell us about your experience?
I took part in the Pan-Canadian lung cancer study using low-dose CT scans. It was taking place in various places across Canada, including, luckily for me, in Ottawa. What was involved was having a low-dose CT scan. The results of that were that there was something, I was told, that needed to be looked at. It was, due to the size, it was suspected that it would be cancer. About 6 weeks later, I had a lung biopsy, which confirmed that, in fact, I had cancer. But I was very fortunately immediately told that it was very early, very small cancer, and that the likelihood of things going well for me was high. That has been the case. I had a lobectomy. I had the top third of my right lung removed. The surgery was done thoracically, VATS it's called, so minimally invasive. I was home and well with just Band-Aids on the incisions in 5 days. Today, that's over 10 years ago. That was October of 2010, and today I am considered cured.
Wow, that's fantastic. Dr. Melosky, how many of your patients would have a similar experience?
Well, unfortunately, I'm a medical oncologist, and so I'm not really seeing those patients who are screened and are as lucky as our previous speaker, and I think that's wonderful as well. And I hope one day I'm out of business, because I hope one day that, as Paul said, that screening really does catch these earlier cancers, so patients don't have to see me with advanced disease.
Does chemotherapy or immunotherapy ever make inoperable cancers operable?
That's a really good question, and we're just looking at that, sort of those questions now. When we think of treatment before surgery, we call that neoadjuvant, and there's some really exciting data that chemotherapy and immunotherapy, or the combination, or they can actually downstage tumors and sometimes make them even disappear. So we really look forward to seeing those trials roll out with survival advantage. But it's really, that's the exciting part of this before surgery treatment.
Okay, we need to take a short break. We'll be right back with more of theZoomer.
We often will end up dividing the lung cancer community into those who are guilty and those who are innocent.
People who have lung cancer have to deal with something more than the disease, and that something more is stigma. And it's mainly because of the connection to smoking. Stigma is particularly pernicious because studies show it often leads to delayed diagnosis and treatment. So, how can we make lung cancer stigma a thing of the past? I'd like to begin with Debi. When you were diagnosed, did you suffer the effects of stigma?
Oh my, yes, absolutely. From those around me, and including self-stigmatizing, I suppose you'd say, I had guilt because I felt responsible for having the cancer. My father had died of lung cancer many years before, and so I was well aware of what the possibilities were for me. I had quit smoking for 13 years when I was diagnosed, but as I say, a lot of guilt to see what I was putting my friends and family through. There's a lot of shame associated with smoking. That's a very detrimental thing and a big part of the stigma, because a lot of people feel we did this to ourselves. I have been told, fortunately not terribly many times, but enough to have an impact, that I didn't deserve to have a program, a treatment that saved my life, basically, because I smoked. I can't imagine anything much more cruel to say to someone. We don't stigmatize any other cancers that same way, despite the fact that research now shows that many cancers have other environmental risk factors associated with them. So yes, stigma is a big problem for both those who had a relationship with smoking and those who didn't, because it tends to be the very first question that you're asked when someone hears that you've got lung cancer is, did you smoke?
I'm sorry to hear about all that. And, you know, it's interesting, the comedian Kathy Griffin was recently diagnosed with lung cancer. And as with some other people who've never smoked, the big message right away is, gee, I never smoked and I got this, Stephanie Snow.
So it's interesting because definitely those first three words, did you smoke, are incredibly harmful. They cause those feelings of guilt and shame. But also sometimes those next three words, I never smoked, can also be harmful because we often will end up dividing the lung cancer community into those who are guilty and those who are innocent. And so the whole point is it doesn't matter if you smoked or not. Nobody deserves to have lung cancer. A smoking history is important for us to take as medical professionals. However, it should not be addressed as a behavior or a moral choice. It has to be addressed as an addiction. And it's not patients' fault that they become addicted to tobacco. That's just the engineering of the cigarette. And so it's very important that we focus on the fact that anybody with lungs is at risk for getting lung cancer. And that focus has really taken away from some other patients' awareness of lung cancer because there are other risk factors, as Debbie mentioned. And so we have less and less research focusing on, for instance, the impact of pollution, asbestos, radon in homes. And at the end of the day, for other cancers, when you get a diagnosis, you get approached with empathy and sympathy, but with lung cancer, there's that sense of blame. And that's what we need to do more education about, that it doesn't matter if you smoked or not. Nobody deserves to get this cancer.
Dr. Wheatley-Price, being a bit of a devil's advocate, what about people taking responsibility?
I think, Dr. Snow's mentioned that as well about, the addictive ingredients that are in cigarettes, which do make it very difficult to quit. And of course, we encourage smoking cessation. We provide support for smoking cessation, and public policy around tobacco usage is important. But at the end of the day, when we're talking about, people who have been diagnosed with lung cancer, it really doesn't matter if you worked your tail off to quit smoking many years ago, or if you're still a smoker, or if you've never been exposed to tobacco. We're going to look after you just the same. Lung Cancer Canada and the Lung Health Foundation joined forces on an anti-stigma campaign earlier this year called thewrongquestion.ca. People can go and look at that website. And really, we need to have some sort of societal shift away from this, because you don't want the first question when you get lung cancer to be the wrong question. You really want it to be, how can I help you?
What about secondhand smoke?
Well, actually, I don't want to pass the buck here, but Dr. Snow mentioned some of the other risk factors for developing lung cancer. So the biggest risk factor, of course, is having lungs. And just recognize, if you've got lungs, you can get lung cancer. And we've seen, many young women who have never been exposed to tobacco develop lung cancer, and we've seen people who work in mining. So, there's certainly pollution, maybe radon exposure, secondhand exposure to exhaled tobacco within the home or within, those who work, for example, in the hospitality industry. So, there are other risk factors, but there is a whole, there's some suggestion about even cooking, like with hot oil cooking in a poorly ventilated kitchen. That suggested that might cause or contribute to lung cancer, wood burning fires. There's all sorts of other theories that have not really been investigated quite as much. I think, some of this public policy, though, around making tobacco-free, restaurants and bars, etc., that we've seen in the past few years has been very effective.
And Debi, have you seen any change in that whole stigma piece since you were diagnosed?
There has been change to the positive because there's so much more awareness now and so many more, as was referred to earlier, people surviving longer. When I was diagnosed, as I say, the fall of 2010, one of the first things I did was go to the library at the Ottawa hospital to get information. And the librarian, first of all, told me she was very surprised that I asked out loud because most people don't want to let on they had lung cancer. So she was taken back by that. But also, when I asked about support groups, she said, I'm afraid not, because they just simply don't live long enough to survive, to create them. The point there is, here we are almost 11 years later, and so much has changed. Lung Cancer Canada has all kinds of programs and has given us, the community, patients with lung cancer, all kinds of support, and really, really worked hard to get awareness out of all aspects of the stigma, the types of treatments, and so on. So we have a lot more voices, and that is helping because there's a lot more awareness that there are these other factors. And as we kind of like to say that, yes, smoking is a risk factor for getting lung cancer, but it's certainly not a requirement.
When we come back, new therapies to treat lung cancer. Stay tuned.
We do have a handful of patients whose cancer essentially disappears, and they can go for a long time, many years, with no sign of the cancer.
Welcome back. For decades, doctors mainly used surgery, chemotherapy, and radiation, but the biggest advance in recent years has been a different type of therapy, immunotherapy. It harnesses the patient's immune system to fight the cancer, and it's particularly successful in treating lung cancer. So how does it work, and how does it allow patients to live longer? Let's start with Dr. Melosky.
Well, how I explain it to patients, and I put it in very simple terms because it's not that simple, but I explain to them that, when your immune system comes towards the cancer puts it to sleep. And so what these drugs called immunotherapy are actually doing is they're stopping that interaction. They're not actually attacking the cancer. They're waking up your own immune system. And, it really has been remarkable. I shamelessly should admit that maybe 10 years ago, I would say to patients that we'll never have immunotherapy because it's too complex. When really now we do. And we actually, as Stephanie Snow said, or Dr. Snow said, have been using these drugs for about 5 years. And we have 5-year data to show that patients are actually alive. And I never would have believed that 10 years ago.
Now, if immunotherapy is successful, are the patients considered to be cured, or is it a remission, Dr. Snow?
Well, it all depends on what stage we're treating that patient. Most patients receiving immunotherapy do have incurable cancer. We never use the word cure there, but we do have a handful of patients whose cancer essentially disappears, and they can go for a long time, many years, with no sign of the cancer. Unfortunately, it's not the case for most of our patients, but we definitely see them living longer and living better. We also use immunotherapy in the curative intent setting. So as Dr. Melosky referred to, for stage 3 lung cancer, we treat a lot of those patients with a combination of chemotherapy and radiation for cure. And if they show a response, if they receive a year of immunotherapy, we see 10% higher numbers of survivors 5 years out. And right now, we're just seeing the beginning of the results of the trials for patients who've had surgery, followed by what we call adjuvant chemotherapy or insurance chemotherapy. If they receive immunotherapy, we're starting to see that we can at least delay the return of their cancer. We just don't know yet if we're truly curing more people because those results take longer to come out.
Dr. Wheatley-Price, so what percentage of patients respond to immunotherapy, and how far along are you in terms of figuring out which patients will respond to immunotherapy?
So, great question. I think when we meet people with lung cancer now, roughly speaking, we can categorize by 3 main factors. One factor is what Dr. Snow was alluding to earlier, which is understanding the genetic sort of signature of the cancer. And through that, we can identify lots of different subtypes, many of which can be treated with tablet treatments or targeted therapy. So that's not immunotherapy. But really very, very effective, and many people now living with stage 4 lung cancer for many years with targeted therapies. So that's one big bonus. And then the second group is those that have a chemical or a protein that sits on their cancer cell, and it's called PD-L1. So if people listening to this have lung cancer, or they know people with lung cancer, a question to ask is the PD-L1 level. That's really important to us, because if the PD-L1 level is very high, that, using Dr. Melosky's example, that's like a lot of sleeping tablet being given out by the cancer. So the PD-L1 is switching off the immune system. And those are the ones where we can really block that with immunotherapy drugs on their own. And I saw a guy, he's 82, he was diagnosed with stage 4 lung cancer a couple of years ago. He has a high PD-L1 level. He's been receiving an immunotherapy drug called pembrolizumab. And Monday was his 2-year immunotherapy cancerversary, if you like. So he was able to finish a full 2-year course. He's had what we call a complete response. The cancer completely disappeared, and his prognosis is looking really good. Now, the third category, so not the targeted treatments, not immunotherapy on its own, it's when that sleeper agent, the PD-L1 level is low or not there at all. Still, immunotherapy can be effective in those patients, but not on its own. We have to boost it with traditional chemotherapy. And that's been the group that, we were a bit more worried about, that maybe immunotherapy wouldn't work so well. But we're getting more and more information now that if we use that combination, we're seeing more and more people also live for many years.
Dr. Melosky, what about the side effects? I know that a lot of people, when they hear something like harnessing your own immune system, they think it's kind of benign, but side effects can be pretty grim.
Yes, I think the beauty, though, about the immunotherapy is that the side effects are really quite minimal. There are some patients whose immune system is already active, and if you were to make it even more active, then you're going to run into problems. The body will start attacking itself, and then you might get joint problems. You might get problems with your bowels. You might get problems with your skin or your lungs. So, the immunotherapy side effects can be really any part of the body. But I think the good news is, in the majority of patients, they're really quite mild. In fact, chemotherapy has much more side effects than immunotherapy when they're used sort of separately.
Just also as a general question, do you have a sense why immunotherapy is good for lung cancer, it's good for melanoma, but not for other cancers? Do you understand that?
Yeah, and I think in very sort of simple terms, and the way I sort of think of it is those two cancers you just mentioned have a lot of antigen exposure. What I mean is, you think of melanoma, it's had all the carcinogens from the sun. In lung cancer and smokers, it's had all those carcinogens from the cigarettes. And so there's going to be a lot of antigens that the immune system should be attacking, but is put to sleep by those cancers. And so those are the perfect sort of storm for immunotherapy to work.
Debi, you did not have immunotherapy, but what's your reaction to seeing an advance?
Oh my gosh, exciting. In terms of what I've seen, thinking of my father being diagnosed 4 months before death with lung cancer in 1997, there was no hope, no nothing. He was just told, we have some palliative radiation. To see that, then myself in 2010 and now 2021 as we are, it's awesome, it's amazing. There's so much more hope, and that is something that did not exist much that I saw 10 years ago, and there's lots of good reason for hope now.
Are there even more immunotherapy drugs on the horizon?
There are, actually. So at the moment, there's about 5 immunotherapy drugs that have Health Canada approval and are in use. And what we're looking at now is actually newer ways of giving immunotherapy. Can we give them in combination? There's a whole new group of immunotherapy agents that we hope can work alongside our current ones to make them more effective. A great example of that is in not lung cancer that we're talking about, but mesothelioma, which is a cancer of the lining of the lung. And we've just learned in the last 12 months that by using a combination of 2 immunotherapy drugs, that really helps people live much longer than if they were having chemotherapy, which was the previous standard. So there's a lot of work going on in this. There's lots of exciting research.
Sounds good. We'll be right back with more of the Zoomer.
Then in many ways, lung cancer in Canada is a postal code diagnosis.
Welcome back. As with most cancers, when lung cancer is detected early, patients have a better prognosis and more options. However, screening for lung cancer is just beginning here in Canada. BC was the first province to announce a program, but it's not being launched until 2022. Ontario has a program underway, but it's not yet established throughout the province. Quebec and Alberta have pilot projects that haven't started yet, and there are a few others funded by government agencies across the country. The idea of screening for lung cancer has been controversial, and the criteria for who qualifies are pretty strict. So let's get into it. Dr. Wheatley-Price.
I think the truth is the last 12 months has been an amazing progress for us. We had nothing 12 months ago apart from one small pilot program in Ontario and some ad hoc efforts. There's been so British Columbia announcing their program to start in a few months from now is big. Ontario turning their pilot, recognizing that it's beneficial and it works, into a program is huge because a lot of other provinces and jurisdictions do look to the big provinces of either Ontario or Quebec, and when one of those goes, there's a lot of pressure to follow. So sure, there's a long way to go to establish this, but this is this has been a really good news year for lung cancer screening. Now you mentioned who gets into the program. It's not feasible right now to offer the whole population of Canada annual CT scans. You have to identify who is at what is a reasonable risk to start with. So what threshold should we say, if your risk is above that, you really should be in the screening program. Mostly at the moment that's based on age, tobacco exposure, but some other factors, including gender, educational level as well, which is interesting. So that's one challenge, is implementing. Then another challenge is going to be adopting it. So there are some issues around equity in Canada with making sure that really our vulnerable communities who often are at higher risk of lung cancer, to make sure screening reaches them too.
So what I was just wondering about actually was, why did it take so long for the idea of lung cancer screening to be adopted when we've had, mammograms for many years? Dr. Snow, do you have a...
Absolutely. So it took us a long time with research to really find the best way to do lung cancer screening. And the first positive trials for lung cancer screening were those that were looking at the low-dose CT. And that technology is newer. As Dr. Wheatley-Price mentioned, it's the newer technology that seems to be more effective. And it's a more complicated type of screening than mammograms because it's a CAT scan, but you also have to have annual follow-up for a number of years. And we also have to look downstream. If you have a positive screening test, do we have the resources to get a biopsy, to do the next test and the next test, so that we're not going to end up with a bottleneck of people with positive CT scans, but not able to have made enough forward planning in order to appropriately provide care for those patients. As Dr. Wheatley-Price also mentioned, we have really sobering data that in many ways lung cancer in Canada is a postal code diagnosis. We know that patients who are from rural areas as opposed to urban areas are more likely to develop lung cancer, and also those patients who are coming from a lower socioeconomic status. If you live in a rural area in Canada, you may be much less likely to have a family physician. You also may be more likely to work in a resource-based industry with other occupational exposures, for instance, mining, or more exposure to things like diesel fuels. And so we really have to look at some of these different populations. And one of our specific populations we need to focus on from the question of equity, of course, are our First Nations populations, because they have many barriers to receiving the best health care compared to many other socioeconomic and ethnic groups in Canada.
I'd like to drill down on who qualifies for screening. I was reading, and I want to make sure it's accurate, that it's people who've been smoking for 20 years, a pack a day. Is that right?
That's right. The main criteria are age 50 to 74 with what's called a 20-pack year exposure. And that's, an average of a packet of cigarettes a day for 20 years. So half a packet of cigarettes a day for 40 years, or 2 packets a day for 10 years. You don't have to be a current smoker. People could have quit a long time ago. So that's the current criteria, and that's people who we think have more than a 2% risk of developing lung cancer over the next 6 to 8 years or so.
A slightly political question, I guess, Dr. Snow, does the fact that healthcare is provincial make something like rolling out lung cancer screening all the harder?
Absolutely, because each province has to make their own program, make their own project to bring to their respective Department of Health. That being said, we do have CPAC, our Canadian National Group, which has an overriding committee and full section just on cancer screening and prevention, who provided a lot of resources which each province can use. As a national patient advocacy group at Lung Cancer Canada, we can work with each individual province, say, what can we do to help you? And one province might need a letter to go along to support their project. Other people might need some extra links to resources. And so as a national patient advocacy group too, we really want to say to each province, how can we help you?
Dr. Wheatley-Price, here in Ontario, we seem to be the only province with a screening program underway. Do you have a sense of how many people will be screened this year or next year?
I wish I did. I don't have those numbers for you, I'm afraid, Libby. The high-risk screening pilot, which is what we had before, existed in 4 centres in Ontario: Ottawa, Toronto, Oshawa, and Sudbury, I believe. So now that's been converted into the Ontario Lung Screening Program. There'll be screening sites opening across the province. And we also have to recognize that this particular population who are eligible for screening, because of their tobacco exposure, it's quite possible that something else will be found on their lungs that is not life-threatening, that is benign, but there is some abnormal little scarring or something. So there needs to be some mechanism for everyone who funnels into a screening program, for those who really look like there's something sinister going on, to be transitioned into a diagnosis, but others to be transitioned into okay, you're clear, come back next year. And then there's this middle group who need sort of different surveillance. So it is complex to build a program like this for lung cancer. So I think we're just going to have to sort of watch this space, Libby, and see how quickly Ontario opens up new sites.
Now, wasn't that the reason that some people were worried that it could do more harm than good, that you would find things and people would get all upset and maybe get unnecessary biopsies? Was that a thing?
That is a thing. That's a thing for any screening test. Is you have to say, well, we're looking for something that we're probably not going to find, but you're at slightly higher risk, so we're going to look because if we find it now, you've got a much higher chance of cure than if we find it later. But recognizing that the test could have a problem. Now, low-dose CT scans actually in themselves don't, but if you're going to put people through lots of biopsies, for example, when you're going through someone's lung to get to is potentially a lot more risky. You can cause a punctured lung or other bigger problems. We're not in the business of trying to deprive people of screening tests or effective investigations, but we are in the business of trying to, be scientific and rational about assessing risk.
And there's more after the break. Don't go away.
Can I just sort of push back on that question, because we're in danger of going down the stigma route again.
Welcome back. Let's check in with our audience for their questions. The first question comes to us from Stephen. He writes, is it true that when you quit smoking after 10 years that you are at half the risk of an active smoker, and after 20 years you are at no more risk for lung cancer than someone who has never smoked? Is that true, and why? Dr. Melosky.
Well, it's approximately true, but your risk, unfortunately, if you have a significant history of smoking, never goes down to those of a never smoker. But you are right. With time, the risk continues to decrease, and quite dramatically. So I think any time is a good time to actually stop smoking.
Our next question is from Tom, who is with our live virtual audience. Tom, go ahead.
Yes, as my name is Tom. I'm 62 and here from beautiful British Columbia. And originally I lived in Vietnam until I was 10 years old, and then I came here when I was 16. Talking a lot about the environment as such as secondhand smoke and pollution as a big factor in getting lung cancer. My question is, how much does genetics play a role in getting lung cancer?
Genetics plays less of a role in lung cancer than it does in some other types of cancer, for instance, breast cancer or colon cancer, but there still is a familial risk. So if you have a first-degree relative, which is somebody who's your parents, your siblings, or your children who have lung cancer, you would have a higher risk than somebody who did not have that same family history. In general, however, the most predictive risks are those environmental exposures. So things like the tobacco smoke, and a lot of patients from Asia have had a lot of more exposure to things like pollution compared to what you may have right now in beautiful British Columbia. And we had heard earlier from Dr. Wheatley-Price that things like cooking fumes can be a big factor. And a lot of that we see in women who are cooking in China, for instance, who are cooking over charcoal fires, and they don't have great ventilation. So it's interesting for those patients, their cooking history is more predictive of their risk of lung cancer than actually a smoking history.
Daria, at the table, your question.
Hey, Libby. So my question is are you more susceptible to lung cancer if you quit and start smoking again and quit and start smoking again?
Dr. Wheatley-Price?
Can I just sort of push back on that question, because we're in danger of going down the stigma route again, where we separate people into tobacco exposure or non-tobacco exposure, and when I moved to Canada about 15 years ago, I discovered the butter tart. I like butter tarts. What can I say? Particularly if they've got the raisins in. And I probably went through a phase where I ate too many butter tarts. I'm sure that put me at a higher risk of having a heart attack if I carried on with my butter tart enjoyment. And when I'd be rolled into the emergency department with a heart attack, I don't think I would be judged because of my butter tart enjoyment. And we've got to kind of, I think, get away from this. We know that there are lots of things that we all do in our lives around our health that we could do better, whether it's what we eat, whether it's how much we exercise, whether it's tobacco exposure. So I think we can promote just general healthy living behavior as the medical community, but just as our society, and then we'll take people who come through the door, whatever their history.
Stick around for more of theZoomer. We'll be right back. Now it's time for final thoughts from our panelists, starting with Dr. Melosky.
My final thoughts is that it's a really exciting time to be a treater for thoracic malignancies. We see such change, and I go to a lot of meetings, and every meeting I go to, something new comes up, and it's just a really exciting time. And it's the big winner here is actually the patient. And so I think I'm proud to be Canadian. As you can see from my colleagues, we work all well together. We all have the same goal, and that's to help each other, to help patients, and not only in our own provinces, but throughout the country.
Debi Lascelle.
Thank you. My final thoughts are similar. It is a great time to be involved in this advocacy that I'm doing. I have met many on the panel. I have had conversations with Dr. Stephen Lamb, who we were speaking about earlier. There's so much great research and interest and support for lung cancer patients in Canada. It's amazing. And it really is a great feeling to be a part of helping so many patients. And it's a good feeling. Thank you.
Dr. Snow.
I think we've seen a lot of positive changes. We're seeing patients living longer. And I think that in the future, as we roll out those types of initiatives like screening and improving the treatments that we give up front for those with earlier stage disease and actually curing more patients, we're really going to see those numbers continuing. Finally, for a patient who's living with lung cancer, as a lung cancer survivor, and their families, I really think that we're starting to do a lot more to change the stigma. And so it's hard enough to have that diagnosis, the guilt and the shame. I think we're moving away from that by starting those conversations and having them out loud in public.
Dr. Wheatley-Price.
Yes, I'd echo Dr. Snow's comments there. And if there are people listening who have lung cancer or someone in their family, then do join us in these efforts, because we really are, bringing, I think, a lot of hope to people. You've heard 22% now is the 5-year survival rate, the biggest jump ever to get to that point. Clearly a long way to go. And I think our big challenge now is going to be that equitable rollout of treatments and screening to all our communities in all provinces and territories.
Lung cancer is still the leading cause of cancer death, but both the incidence rate and the death rate are going down while treatments are getting better. So there's lots of cause for hope. That's all the time we have. Thank you for being with us. Thank you to our panelists. We'll see you soon. It's time to zoom out.